Okay, yeah, perfect. Okay, everyone, kindly ask that you take your seats, and I'm hoping that they can hear me outside there, because we're going to be getting started in just a moment. And I think we've had a fantastic day, and I know that we've had a lot of great discussion also this afternoon at the e-poster session, and we're going to be finishing our afternoon with one of the highlights of the day as well, which will be the second round of the oral presentation from our trainees, both clinician scientist trainees as well as trainees who are working in the research programs of in our Department of Surgery. So with that, a brief introduction, I'd like to introduce Dr. Farshad Nassiri, who will be moderating the next session. And Dr. Nassiri is a staff neurosurgeon and clinician scientist in neurosurgery at University Health Network.
Perfect. Welcome back, everyone. First of all, welcome Professor Nataraja again, and thank you for sharing all your insights. And a major congratulations to Dr. Failings and Dr. Swallow on another amazing Gallie day. So we're going to be continuing on the research presentations in the afternoon. So these will be 10-minute presentations followed by 5 minutes for questions and a discussant. So first, I'd like to invite Dr. Nagoya, who's a postdoctoral fellow at the UHN, and he'll be speaking to us about optimization of non-viral lipid nanoparticle-mediated gene delivery for donor lung engineering. Thanks very much, Dr. Nagoya.
Thank you for the introduction, and good afternoon, everyone. My name is Akihiro Nagoya, a thoracic surgeon from Japan. It's my great honor to be presenting here today, and I sincerely appreciate for this opportunity for Gallie Days Committee. So lung transplantation is an ultimate therapy for end-stage lung diseases. However, long-term outcomes after lung transplantation remain suboptimal, partly due to organ rejection mediated by immune system. Donor lung engineering is an approach aimed at enhancing donor lung function through gene editing prior to transplantation, and hold promise for reducing adverse immune responses. Previously, we focused on human IL-10, a key immunomodulatory cytokine, to reduce adverse immune responses, and successfully achieved CRISPR-mediated IL-10 upregulation using adenoviral vectors. By introducing a mutation into a regulatory element, IL-10 gene expression was enhanced through inhibition of repressor binding. As shown in cell line experiments, CRISPR-mediated gene editing became effective after 24 hours, resulting in increased IL-10 expression. However, this adenoviral system still presents several challenges, including delayed onset of IL-10 upregulation and suboptimal transfection efficiency and adenoviral immunogenicity, highlighting the need for novel gene delivery method optimized for the lung. Lipid nanoparticles, or LNPs, are small lipid particles, typically less than 100 nanometers in diameter, and have gained significant attention following the success of COVID-19 vaccines. LNPs are composed of 4 main components: Ionizable lipids and helper lipids play a crucial role in determining the biochemical property of LNPs, whereas cholesterol and polyethylene glycol primarily fill structure defects and stabilize the particles. In addition to these four main components, RNA cargo enables rapid protein expression. Importantly, by modulating these components, LNP can be tailored for specific gene delivery applications. Based on these backgrounds, we hypothesize that LNPs enable rapid and efficient gene expression, serving as an ideal modality for clinical translation. We began by screening LNP formulations using in vitro models. 5 novel ionizable lipid, P3S, L1, U3-Cyc, ST1, and ST3 were formulated with one of two helper lipids, DOPE or DOTAP, and a reporter gene mCherry mRNA. Transfection efficiency was assessed in human cell lines using flow cytometry. 2 LNPs used in COVID-19 vaccines were included as benchmark controls. Among all formulations, ST1 DOTAP shows the best transfection efficiency. We then focused on ST1 DOTAP and assessed its gene expression kinetics using human precision-cut lung slices. Lung slices were prepared from human lungs declined for clinical use. We administered either adenoviral vectors or ST1 DOTAP carrying mCherry and cultured the slices for up to 1 week and evaluated protein expression over time. Compared with adenoviral vectors, ST1 DOTAP achieved a faster peak in mCherry expression, with maximum level observed 2 days after administration. Next, we evaluated the gene delivery efficiency of LNPs in vivo rat models. ST1 DOTAP formulated with mCherry mRNA was administered to the left lung of rats, and protein expression and cellular tropism was investigated. mCherry expression peaked 2 days after administration and was largely restricted to the left lung. Immunofluorescence staining showed mCherry co-expression in 10.5% of pancytokeratin-positive epithelial cells. Flow cytometry analysis further confirmed that epithelial cells were the most predominantly transfected, with a rate of 13.6%. However, during in vivo studies, we observed that high doses of LNPs induced lung injury. In the left lung treated with 500 microgram per kilogram of ST1 DOTAP formulated with mCherry mRNA, localized lung damage was evident on gross inspection. As shown in the radar chart on the right, we analyzed the expression of inflammatory genes in the left lung using qPCR by plotting relative CQ values normalized to control rat kidney. This analysis revealed upregulation of inflammatory genes including IL-6, MIP-1 alpha, emphasizing that further optimization is necessary to reduce LNP-induced inflammation. We recently obtained a novel ionizable lipid, CX656, designed to reduce the toxicity of ST1. When DOTAP formulations differing only in the ionizable lipid were compared, CX656 induced significantly less inflammation than ST1. as evidenced by both gross appearance and reduced expression of inflammatory genes in qPCR analysis. To validate the concept of LNP-mediated gene delivery to the lung, we moved forward with the expression of human IL-10. Our previous study indicated that an HIL-10 concentration between 20 to 80 picogram per milligram protein in lung tissue is ideal for repairing damaged lungs. As shown in the graph, when the dose of LNP was increased to 50 microgram per kilogram, we successfully achieved this therapeutic window. qPCR and histological analysis revealed LNP-induced inflammation in the left at a dose of 10 microgram per kilogram. However, this inflammation was alleviated at a dose of 50 microgram per kilogram. To summarize, LNP enable rapid and efficient gene delivery. Optimization of LNP minimized LNP-induced inflammation. However, since LNPs could be toxic, LNP requires careful optimization before clinical translation. So this project was supported by many people. I'd like to thank everyone in our Latnas labs, especially for my PI, Dr. Akshav Keshavji. And I'd happy to take any questions. Thank you very much.
Thank you very much, Dr. Nagoya. Very elegant work. I'll invite Dr. Andras Kapush to come and give a few words as well.
So congratulations on these really pioneering studies, very novel, very exciting. A couple of questions. I think the real problem or challenge is that the LMPs all have some inflammatory effects. So I was wondering if we compare really the adenoviral versus LMP-mediated responses at the same dose with adenovirus, where you reach kind of the therapeutic level of IL-10, what are the levels of inflammatory cytokines, so particularly IL-1 beta and IL-6?
So it's difficult to use the exactly same dose. Compare the dose of virus and LNPs because the unit we usually use is completely different. But we haven't actually looked into that. But in my expression, in terms of IL-10, when we use the same dose that induce the same amount of human IL-10 in lung tissue, I think LNP is much cause less toxicity.
I see. And maybe I would ask the reverse side of this question too. So if you just add the LMPs alone, but without delivering the IL-10 gene, what are the consequences in terms of, let's say, IL-10 expression, because I think it induces some, and what are the consequences in terms of the inflammatory cytokines?
So again, we've never tried this experiment because without RNAs, LNP changes its conformation and its distribution will be completely different. But some research group did that, and even without RNAs, LNP itself caused some inflammation. And so
it also increased, although the IL-10 level?
Yes, because of all the inflammation, not only IL-6 or IL-8, but it also increases IL-10. But when we add IL-10 mRNA, the level is not comparable. Much higher.
Thank you very much.
Professor Swallow.
So I noticed that the CRISPR adenovirus technique resulted in a sustained increase in IL-10, whereas the LNP was a sort of quick spike and then decrease. So clinically, which is necessary? How long does it have to be sustained for?
Thank you for the great question. So we are assuming there are two phases for IL-10 upregulation. The first is acute spike of IL-10 that alleviate ischemic lung perfusion injury. And the later phase is like chronic phase, which many patients requires lifelong immunosuppressant. And we are assuming that by upregulating IL-10 constantly, we can reduce the dose of immunosuppression and can reduce the immunosuppressant-associated adverse effect. So we are planning to combine human IL-10 mRNA and CRISPR RNA and achieve the acute spike followed by gradual IL-10 upregulation.
I'll ask one question as well. Do you I think you've had a very elegant way to kind of mediate the inflammatory-induced lung injury. Do you think that that's the only mechanism by which the lipid nanoparticles are inducing lung injury? Is there metabolic or other pathways that could be inducing some degree of injury?
So we have never looked into that, but many literature suggests that the biggest contribution of LNP-mediated inflammation is caused by ionizable lipid. When it escapes from endosome, it changes the pH or intercellular environment and causes cell damages. But yes, as you said, LNP can cause inflammation via other mechanism, and we'd like to investigate that.
Last question, Keith.
Really nice talk. I was just curious about the toxicity in terms of the species differences, and if you guys have done any investigation of looking at differences in inflammation, let's say in a mouse model versus a rat model, and then if there are species differences, how does that relate to the human model? And also, I guess related to the IL-10, do cytokines crosstalk between human and rat? I know in mouse, for example, they often don't. In rats, is that the case?
So as for the second question, yes, human IL-10 actually work to reduce the inflammation of rat or even pig inflammation. So there are some crosstalks. And in terms of the first question, that's what we really want to look into in the future. So depending on species, we found different inflammation, especially, for example, specific type of RNA. We actually detected different inflammation reaction. So what we are planning to do next is using human lung to actually assess the LNP-caused inflammation.
Thank you very much, Dr. Nagoya.
Thank you
Next,
so
I'd
much.
like to invite our next speaker, Dr. Nitish Dhingra. He's a cardiac surgery resident doing a PhD through the IMS. He's a surgeon scientist trainee program trainee and speaking on outcomes of pediatric donors for adult recipients in heart transplantation. Thank you very much.
This one here? Perfect. All right, well, thank you, everyone. My name is Nitish Dhingra. I'm one of the cardiac surgery residents and a first-year PhD student here at the University of Toronto. It's really my honor, on behalf of my co-authors and the rest of the International Consortium on PGD, to be presenting this analysis evaluating heart transplant outcomes with the use of pediatric donors for adult recipients. So in an evolving landscape where mechanical circulatory support is certainly maturing and advancing medical therapy, heart transplantation really still does remain the gold standard therapy for patients with advanced heart failure. But we also know that there remains a wide gap between the number of patients that are waiting for this life-saving intervention and the reality of what we can provide based on limitations in donor availability and utilization. And that's why over the past decade, this is data from the United States, there's been a big priority on expanding the donor pool. So if you look at the bottom of this graph here, more utilization of donors with advanced donor age, longer ischemic times, hepatitis C, and newly the advent of donation after circulatory death. And all of this has been designed to expand access to heart transplant through expanding the donor pool. But we also know that expanding the donor pool has to be done so thoughtfully and with careful attention to the impact on both short and long-term outcomes. This is recently published data from the United States that show that there is survival differences between heart transplant recipients that get donors above the age of 45 compared to those that get donors under the age of 45. But what remains unknown is at the opposite end of the spectrum, with the use of pediatric donors for adult heart transplant recipients, the impact that that may have on, again, short and long-term outcomes. There are theoretical concerns with the use of pediatric hearts for adult heart transplant recipients that give clinicians pause in accepting these donor hearts when they get offered. So, adolescence is characterized by a variety of changes in both the structure and function of the heart. Vascular mismatch, which has important implications for anastomoses and perturbations in flow. And importantly, specifically, the afterload conditioning of the pediatric right ventricle, is a lot different than the afterload it will experience in an adult recipient. And all of these, like I say, give pause and give us reason to consider when accepting these donor hearts. So really the purpose of this analysis was to comprehensively evaluate both the safety and the efficacy of using pediatric donors for adult heart transplant recipients. So how did we do this? Well, we leveraged the International Consortium on PGD database. This is the largest international database that's dedicated to the study of primary graft dysfunction after heart transplant. It now includes 15 centers, over 4,000 patients from Canada, the United States, and Europe. So we took, intentionally broad inclusion criteria. All adult heart transplant recipients were eligible for this study. We excluded those with missing donor age data and those enrolled after 2024 to make sure we had sufficient follow-up data. And we essentially stratified them based on their donor age. So those with donors less than 15, 15 to 18, sort of that adolescent phase, and then above the age of 15. We looked at a primary outcome of severe primary graft dysfunction. So this, using the 2014 ISHLT definition, essentially means that patients after heart transplant required either VA ECMO or ventricular assist devices within 24 hours after transplant due to failure of the new graft to support the patient's circulatory demands. The secondary outcome was all-cause 1-year mortality, and we did this through adjusted analysis. So we used multivariable logistic and Cox regression models for severe PGD and mortality, respectively, and we pre-specified the following covariates with donor age and also adjusted for predicted heart mass ratio, which is obviously very clinically important when thinking about using pediatric donor hearts into adults, and then recipient donor age difference as well. And we evaluated the nonlinear association of these covariates with outcomes using spline curves. We did multiple imputation for missing covariates. So these are results. We included a total of 3,787 global heart transplant recipients. The vast majority of these did receive donor hearts from adult donors above the age of 18, about 94%. The remaining 6% received pediatric donor hearts from donors under the age of 18. These are baseline characteristics, so these are recipient characteristics we're looking at specifically. So as you would expect, the recipients of pediatric donor hearts were more likely to be younger, they're more likely to be of female sex, and they were more likely to have congenital etiologies for their heart failure as opposed to, for example, ischemic cardiomyopathy, which is more common in those receiving older donors. Importantly, however, previous sternotomies, durable LVADs, temporary mechanical support, and mechanical ventilation, sort of negative prognostic factors for transplant outcomes, were all equally distributed across these three groups. These are now donor characteristics. Surprise, surprise, the pediatric donor hearts were younger. They were less likely to be have female sex. And in terms of cause of death, the pediatric donors were more likely to have a primary cause of death related to anoxia, whereas the older donors were more likely to have a cause of death related to stroke. These are procedural characteristics. So importantly, pediatric donors were more likely to be used at North American centers and high volume centers compared with the more traditional donors that are used in lower volume centers. But we saw no difference in ischemic time across these three groups. So these are our unadjusted outcomes. So for severe primary graft dysfunction, we did see numerically less severe primary graft dysfunction in in recipients receiving hearts from pediatric donors, this didn't reach statistical significance. And similarly, we saw no statistically significant difference in 1-year mortality between these 3 groups. But that's unadjusted outcomes. Now, let's look at our adjusted analysis. This is for the primary outcome of severe primary graft dysfunction. So this is the spline curve that we generated. You can see the x-axis here is donor age evaluated continuously. The y-axis is essentially the risk of developing severe PGD, with the median line at 0 representing at that line no association at that point between donor age and severe PGD. And what you can see is at the age less than 18, there's in fact a significant protective factor reducing the risk of severe primary graft dysfunction compared to those with older donor age, and this relationship did reach statistical significance. We saw no relationship between predicted heart mass ratio and the risk of severe PGD. You can see the confidence intervals are quite wide there. But interestingly, we did see this sort of U-shaped relationship between recipient donor age difference and the risk of severe PGD, wherein at either extremes of recipient donor age difference, meaning recipients that were much older than their donors or donors that were much older than their recipients, we saw an increase in risk, and this was marginally significant with a p-value of 0.06. Now, what about 1-year mortality? Very similarly, once again, we saw a protective relationship wherein the pediatric donors had a lower risk of 1-year mortality compared with older donors. This relationship again reached statistical significance. No relationship between predicted heart mass ratio and no relationship between recipient donor age difference with 1-year mortality. So in summary, pediatric donor heart acceptance for adult recipients remains rare, represents about 6% of transplants in our database. Younger donor age was independently associated with a lower risk of severe primary graft dysfunction and 1-year mortality. And we did find a trend towards a higher risk of severe primary graft dysfunction at the extremes of recipient donor age difference. This really corroborates some previous data that has been published. This is data from UNOS that was published a little while back, comparing donors under the age of 14 with donors above the age of 18, and they saw really no difference of survival up to 5 years. But I think the current data really adds to the existing body of literature by representing the largest contemporary data sets with novel preservation strategies and novel sort of donor acceptance practices. And importantly, is also international, like I mentioned, with heart transplant recipients across Canada, the United States, and Europe. So really improving the global generalizability of these findings. That's not to say that there aren't limitations. This is obviously observational and retrospective data. And so, the careful ways in which these donors and recipients are selected and matched does represent a source of selection bias. And despite being the most and the largest and most comprehensive international analysis available, the absolute numbers are still small. So again, this is only 6% of our total data set. So there's obviously a power issue. But nevertheless, in this analysis of nearly 4,000 global heart transplant procedures, the use of hearts from pediatric donors for adult recipients was safe, it was effective, and a potential signal towards improved outcomes. So I just want to take this time to thank my mentors. I want to thank Gallie for the opportunity to present, and I'm happy to take any questions.
Great work, Dr. Dingra. I'd like to invite Dr. Cedric Magniot to give a few words and questions.
Great, thank you. It was a great presentation and a great analysis. Obviously, the elephant in the room here is that your donor less than 15 is less than 49 patients, so less than 50. And that comes with very substantial statistical challenges. In your unadjusted analysis, you have a 5x reduction in mortality, and yet it's not statistically significant. So have you talked about using different method to protect against that kind of confounding, things like propensity matching or inverse weighting, in order to assess better the bias?
Yeah, that's a great question. In fact, I would say that because the absolute numbers are low and the outcome numbers are low, it sort of ties our hands in terms of our ability to overfit. In fact, you could see in our adjusted analysis, we only had 3 covariates, as opposed to, if you have more outcomes, you have a little bit more statistical power to add to those covariates. So that certainly is a limitation. I would say that, part of the interesting finding of this analysis is that itself, is that, like I said, these absolute numbers are low, and there are theoretical concerns that give pause to clinicians for accepting these donors when they're offered. Now, they are prioritized for pediatric recipients when there is a match, but hopefully these data do give at least a signal towards their safety and efficacy for use if and when they are offered.
One important, I think, thing that you mentioned in this analysis is that those recipients that were receiving pediatric donors actually were at very large, were more likely to be in large centers with more resource and things like that. So do you think that the improved outcome is due more to a center effect or more to the underlying biology here?
Yeah, absolutely. So, we know in all of surgery, and certainly cardiac surgery and heart transplant is no different, there certainly is a volume and outcome relationship. And these high volume centers, and in transplant, there certainly is a wide range of volumes and experience. And so these centers are more likely to kind of push the boundaries in donor acceptance and have a system around them that help with outcomes. So the short answer to the question is absolutely. I think that is an important confounder. Unfortunately, like I say, it's hard to adjust for all of these when your outcome event rate is so low, for risk of overfitting and overanalyzing the data that we have. So something to consider absolutely when interpreting this data. Yeah, that's a great point.
Great. And then one final question about, that's because I'm a scientist at Sick Kids, about the ethics behind this. So children have a much larger mortality rate on the wait list than adults already. And so can you talk a little bit about the ethics of now maybe having to compete against adults for fewer hearts?
Absolutely. It's a great question. This is why I love transplant, to be honest, because it lies really at the intersection of science and medicine and humanity and ethics too. I would say that, these data are not designed to encourage changes in the current prioritization. I do think that, to your point, that pediatric recipients are as they are and should be higher priority for, especially for pediatric donor hearts. And certainly these data aren't designed to change that. But if and when, as often, there are no appropriately sized match recipients, or there isn't an available recipient, it also means that we should feel comfortable, still utilizing these donors so that they don't go to waste. Because, like I said, there's obviously a long waiting list of both kids and adults for this life-saving intervention, and so it's incumbent on us to try to maximize our donor utilization as much as possible.
Great, thank you, and I want to commend you for having a statistically rigorous and complex study with a small number of patients. That's really nice to see.
Thanks very much. Thank you.
Congratulations, Dr. Dingle. So next, I'd like to invite Dr. Ben Lee. He's a vascular surgery resident and a PhD candidate in the Surgeon Scientist Training Program. He'll be speaking to us on predicting 1-year successful use of arteriovenous access for hemodialysis using machine learning. Welcome, Dr. Lee.
Thank you, Dr. Nassiri. And good afternoon, everyone. As you know, chronic kidney disease affects over 700 million people globally, and more than 4 million have end-stage kidney disease requiring hemodialysis to sustain life. And arterial venous access is the safest option to support long-term hemodialysis. It involves the surgical creation of a connection between an artery and a vein to increase flow within that vein to support hemodialysis. We can create this connection directly, and this is called an AV fistula, or we can create this connection through a graft, and this is called an AV graft. We generally create AV accesses within the arm, but we can also create them within the leg and in the chest. To help us determine where and how to create AV accesses, we use preoperative ultrasound criteria, primarily an artery diameter greater than 2 millimeters and a vein diameter greater than 2.5 millimeters. And when these criteria are met, we generally proceed with AV access creation. The clinical problem is that approximately half of all surgical AV accesses that we create will fail due to insufficient maturation or other complications. And patients with failed AV accesses will need a temporary central line, additional access planning, and reintervention. And this leads to significant patient burden risks, and costs. Therefore, preoperative ultrasound criteria are insufficient to predict AV access success. Patient demographics, their comorbidities, vascular access history, and medications, among other factors, play an important role in AV access success rates. Clinical tools that can incorporate this information to more accurately predict long-term AV access outcomes can support better access planning, monitoring, and counseling. Machine learning, or ML, is a rapidly advancing field that allows computers to learn from large amounts of data and make accurate predictions. Specifically, supervised learning leverages advanced analytics to model complex relationships between inputs, such as a patient's characteristics, and outputs, such as their clinical outcomes. This field has been driven by the explosion of electronic information combined with increasing computational power. ML therefore provides an important opportunity to develop automated and accurate AV access outcome prediction tools that are practical for routine use. Our goal was to develop an ML algorithm that accurately predicts one-year AV access outcomes using preoperative data. We use the Vascular Quality Initiative, or VQI database. This is the largest vascular surgery registry in the world. It captures data from over 1,000 hospitals globally. Trained database managers prospectively record demographic, clinical, and outcomes data on consecutive patients, from their initial hospitalization up to approximately 1 year of follow-up. Annual audits with comparison to hospital claims are performed to ensure accuracy of the submitted information. We included all patients who underwent surgical AV fistula or graft creation for hemodialysis between 2011 and 2024, patients who received an endovascular AV access, and those with no reported access type, inflow artery, or outflow vein were excluded. We used all preoperative variables captured by the VQI AV access database as input features, including demographics, comorbidities, vascular access history, functional status, labs, medications, anatomy, and surgeon and center case volumes. We added intra and post-operative features for sensitivity analysis, including the type of anesthesia, intraoperative target artery and vein diameters, concomitant procedures, and completion imaging, as well as any immediate complications, hospital length of stay, discharge medications, and non-home discharge. The primary outcome was 1 year successful clinical use of the index AV access for hemodialysis, defined as an AV access that can provide the prescribed dialysis consistently with 2 needles for more than 2/3 of dialysis sessions within 4 consecutive weeks, with or without reinterventions, determined through direct clinical follow-up. We chose this primary outcome because it is clinically relevant, as it requires the AV access to be both anatomically patent and functionally active. The secondary outcomes were 1 year AV access thrombosis, defined as complete occlusion of the index AV access by a thrombus, and 1 year reintervention, defined as endovascular or surgical reintervention on the index AV access to promote maturation or to treat a complication. ML model development followed the tripod plus AI guidelines. We trained 6 ML algorithms: XGBoost, random forest, knife-based classifier, support vector machine, artificial neural network, and logistic regression. We chose these models because they demonstrate the best performance for predicting surgical outcomes using structured data in the literature. We split our data into 70% training and 30% test sets, and we used tenfold cross-validation in grid search to optimize model hyperparameters. The primary model evaluation metric was AUROC. Secondary performance metrics were accuracy, sensitivity, specificity, positive predictive value, and negative predictive value. We further evaluated model robustness using calibration plots and Brewer scores. We determined feature importance by ranking the top 10 predictors based on variable importance scores, and we conducted subgroup analyses to assess model performance across diverse patient populations. And here are results. We included 59,000 patients, 76% received fistulas, 24% grafts, and 47% of patients had 1 year successful clinical use of their index AV access for hemodialysis. This table shows model performance on test set data for predicting 1 year successful clinical use of the index AV access for hemodialysis using preoperative features. We trained 6 ML models, and the best performing one was XGBoost, achieving an AUROC of 0.9, accuracy of 0.82, sensitivity of 0.82, specificity of 0.81, PPV of 0.81, and NPV of 0.82. This performed significantly better than traditional logistic regression, which achieved an AUROC of 0.7. This table shows XGBoost performance on test set data for predicting secondary outcomes, including 1 year AV access thrombosis and reintervention, with AUROCs of 0.86 and 0.88. These are the ROC curves for the XGBoost model, demonstrating excellent performance at the pre, intra, and post-operative stages with AUROCs between 0.9 and 0.91. On subgroup analysis, we found that model performance remained robust, with AU-ROCs between 0.89 and 0.91 on demographic and clinical subgroups stratified by age, sex, race, ethnicity, rurality, socioeconomic status, access type, and access location. These calibration plots show excellent agreement between the predicted probability and observed rate of one-year successful clinical use of an AV access using the XGBoost model at the pre, intra, and post-op stages with the Breer scores shown here. These are the most important predictors in our model, including a higher diameter inflow artery and outflow vein, an access type of fistula rather than graft, use of preoperative ultrasound vein mapping, among others. When we looked at these top 10 predictors, they made sense to us clinically, meaning that our model was explainable. We demonstrated that anatomic features play an important role, but physiologic features, including age and comorbidities, also play an important role, particularly for predicting failure. This is a clinical workflow for how we could use this ML algorithm in the clinical setting. Let's say a patient presents for consideration of AV access creation. You can apply this ML model at the pre-op stage to get a prediction of the patient's probability of one-year successful clinical use of their AV access. Let's say that the model predicts that the patient is at high risk for failure with a particular approach. Then you could further assess the patient's risk factors. If they have anatomic risks, then you could consider another AV access strategy with additional preoperative imaging to determine the optimal access type and location. Whereas if they have physiologic risks, then the patient may benefit from further optimization. You can also apply this model at the intra-op stage. Let's say you take the patient to the OR and you find that their artery and vein diameters are smaller than expected, and the model predicts that the patient is at high risk for failure. Then you could consider another surgical approach with a different inflow, outflow, or conduit and a short hospital admission for monitoring and treatment of any early complications. You can also apply this model at the post-op stage. Let's say the patient develops immediate complications and the model predicts that the patient is at high risk for failure. Then you can schedule early follow-up with imaging and plan for any future AV access options with your appropriate patient workup and counseling. Whereas if they're low risk, you could provide routine pre-discharge care and follow-up. Overall, accurate predictions from this ML algorithm can inform clinical strategies throughout a patient's surgical course to provide personalized care and improve AV access outcomes. In conclusion, we trained a robust ML model using the largest vascular surgery registry in the world. It can automatically extract individual patient data to accurately predict one-year successful clinical use of a planned AV access. Our ML algorithm can guide AV access planning, monitoring, and counseling to facilitate personalized care and improve AV access outcomes. We're now working to prospectively validate this model to support its clinical implementation. We've made this tool publicly available. You can access the full programming code here. This work was recently published in Nature Digital Medicine, and you can access the full text here. In terms of our current and future directions, we're working with the Society for Vascular Surgery to update their VQI online risk calculator to include AV access outcome prediction with ML methods. And we're working to deploy an EHR-integrated ML-based risk prediction model at St. Michael's Hospital. This model will automatically retrieve a patient's demographic and clinical information using their medical record number and make outcome predictions for planned AV access creation procedures. We're currently finalizing this model with our data analytics team with a plan to deploy later this year. I'd like to thank the SSTP program, CIHR, the Ontario Ministry of Health, and the PSI Foundation for funding this work. Thank you very much for your time.
Great work, Dr. Lee. I'd like to ask Dr. Tom Lindsay to ask a few questions, please.
Great, thank you very much. Ben, that was very good. I have to say that when you look at this, having done a few of these that are probably in the database, and I know many of my colleagues have, I'm shocked that the success rate is as low as 47%. I'm sure that if you were doing many surgical procedures, you'd be pretty disappointed with a 47% first-time success rate. And I wonder if that's partly the way you've defined the first-year success. I realize it's a good model of maybe successful dialysis, but it did include secondary interventions. And do you know what impact those secondary interventions had? So that's my first question. And the second question really is, you trained a bunch of different models. The first two models, the XGBoost and the random forest, really weren't a whole lot different. So what's the big difference between those two models and the other models that you showed us? Thank you for your work.
Sure, thank you, Dr. Lindsay. So for your first question about reinterventions, so in terms of how we defined our primary outcome of AV access success, it included an access that underwent a reintervention and still was able to successfully be used for dialysis at 1 year. And as you know, patients who receive AV access disease generally require reintervention to keep the access open. And often these are low-risk endovascular interventions that can be performed by interventional radiology, and the patient goes home the same day. So we decided to include reinterventions within that primary outcome because we know that these are often low-risk interventions. And in terms of why, 50% success rates of AV access, I think there's a few factors. I think patient characteristics in terms of patients needing AV access are generally quite sick. They have multiple comorbidities. And so I think they're already at higher risk for having failure. And I think clinician variability in terms of preoperative workup, I think some clinicians perform, everything, arterial duplex, venous studies, vein mapping, while others don't. And I think that variability also contributes to that outcome rate. So I think with our ML model, that provides an individualized risk prediction for patients. If a clinician sees, okay, this planned AV access outcome, the probability of success is quite low, then probably they need to rethink their preoperative strategy, perhaps perform more preoperative imaging to determine the optimal access strategy. In terms of your sorry, can you remind me of your second question?
The different models, like in other words, the XG boost and the random effects were very similar, but the rest of the models didn't predict it as well. And is there a particular reason why that is?
Yeah, so XG boost and random forest both work based on decision trees, and decision tree models work very well on structured data. And in terms of the difference between XG boost and random forest, so XG boost trains these decision trees sequentially, whereas random forest trains them in parallel. So XG boost, it's a more recent model, and it's demonstrated superior performance to random forest in other settings as well. And because it trains sequentially, this means that every time it trains a decision tree, it learns from its mistake, and every decision tree gets better and better. Whereas with a random forest, it trains all of these trees in parallel, and at the end, it comes up with an average of what all of these decision trees predict. So while random forest trains faster and XG boost trains slower, XG boost generally performs better because of the sequential training.
Thank you.
Dr. Feelings.
Yeah, very, very elegant work, and it's a large data set. So I'm going to ask you a few methodological questions just related to the technique. And so when designing machine learning models, it's important to, one, have some kind of an assessment of the external validity. Is there any kind of it's obviously a large data set, but are there any large external data sets that you're able to access to test the validity of this model?
Yes, thank you, Dr. Feeling. So external validity is something that, as you mentioned, is quite important. The challenge with external validity with a database as large as the VQI, where 1,000 hospitals participate, is that it's challenging to find a hospital that does not participate in VQI to externally validate our models on. We are currently actively working with some of our US collaborators with some of their administrative data sets that do not participate in VQI for external validity, as well as internationally with our collaborators in Saudi Arabia. And that's outside of both VQI and North America, so we're actively working on that.
I think that'll be kind of important, to do. And then there's a number of controls that are increasingly being recognized to test the potential fragility of machine learning. So these include things like missing data or randomly perturbing the model, so changing the input that you put into the, to the variables and so on, to essentially assess the fragility of the model. And this partially gets at Dr. Lindsay's point, because some of these approaches have differing levels of fragility, which can sometimes reflect where a model may work or not. So have you done any of these, or are you considering potentially doing some of these types of approaches?
Absolutely. So the good thing about VQI data is missing data within this database is actually quite low, so it's less than 5%. So we tried different ways of handling this missingness. And the best way that we found was just keep the data missing and let our models train on missing data. And often the models like XGBoost, they consider this missing data as signals. So for example, if a patient is missing, for example, a cardiac stress test, often a clinician has evaluated this patient and said the cardiac stress test is not necessary. So the model learns the signal and says, okay, this patient may be lower risk. We tried different ways of treating missing data in terms of imputation, and we found that predicting with missingness worked the best with our models, and I think this reflects well on how it'll perform in the real world, where, as you know, EHR data, a lot of missing data and messy data, and our models are able to predict with missingness.
Okay, thank you.
Congratulations, great work. Next, I'd like to invite Dr. Daniel Mahmood, another strong representation of vascular surgery, another vascular surgery resident through the Surgeon Scientist Training Program, PhD candidate, who's going to be speaking to us about optimization of computational fluid dynamic simulation inputs for predicting aneurysmal degeneration after uncomplicated type B aortic dissections. Welcome.
Thank you so much. My name is Daniel. I'm one of the vascular residents, as was mentioned, and it's an honor to be able to present our work here. I'll be speaking to you about computational fluid dynamics and acute type B aortic dissection, specifically uncomplicated, and a model that we have developed. We have no disclosures. So aortic dissections are life-threatening conditions, and they're represented or characterized by a tear in the intimal layer of the aorta. It now goes from 1 lumen to 2 lumens, a true lumen where blood is supposed to flow, and a false lumen where blood may or may not be flowing, but you cannot predict that just from a CT scan. And without treatment, mortality reaches up to 50% within 48 hours of symptom onset. Now, when we're looking at type B aortic dissections, classically, we're looking at the intimal tear just distal to the left subclavian artery at the bottom there, bottom right. And uncomplicated acute type B dissections, if there's no malperfusion or rupture, they can be treated with anti-impulse therapy, blood pressure management, IV initially, onto orals, and then discharge. But afterwards, we follow up with them. Why do we do that? Because there are reports that up to 40% will become aneurysmal over time. And when they become aneurysmal throughout their thoracoabdominal aorta, that is a much more complicated repair, whether that be endovascular or open. And so the clinical question is, can we predict those patients that are likely to progress to aneurysmal deformation, and then provide them with an earlier and a lower risk operation in the form of a TVAR to seal off that intimal tear and decrease perfusion to the false lumen, which is going to become enlarged unless we don't. And so currently, there isn't a good way to predict that. But we can look to CFD, computational fluid dynamics. CFD has had some huge, I would say, huge success in predicting rupture after abdominal aortic aneurysms. But the accuracy of CFD in dissections is limited by the constraints of the boundary conditions. Now, what are boundary conditions? If we have an aorta and we would like to know the flow, we would like to know pressure, we would like to know what's going on in the different lumens, we need to provide it an inlet and an outlet. We need to provide it blood going in, blood coming out. The solver will solve everything else in the middle. And there are ground truths to what an inlet and outlet should be. The ground gold standards are either arterial pressure measurements, or you have a 4D MRI where you can extract velocity vectors from them. But in uncomplicated acute type B aortic dissection patients that only need blood pressure medications and then can be discharged, we're usually not going to get those. And therefore, we can't rely on a simulation unless we have strong data. And therefore, our objective is to develop and evaluate a scalable patient-specific CFD model for quantifying lumen-specific hemodynamics in uncomplicated acute type B aortic dissection. So how do we go through a simulation in the first place? Hours of work on a slide, you can start off with the CT scan. After that, you have a 3D geometry of the aorta, which is ready to 3D print at this point. But instead of 3D printing, we make it hollow and we assign 3 million nodes to it, which is the far right image up there. Each of those intersections is considered a node, and a node is a data center. It's responsible for collecting data. So all the wall parameters, velocity and pressure, the nodes is responsible. And then when I provide an equation after running it in console, it gives me the values. And then we created a code itself where we can actually separate out the true lumen and the false lumen. You can see here that the false lumen there is in purple, and those nodes can become your data points of a specific lumen. And what parameters do we want to look at when we're considering making a model? To to keep it simple, we want to look at 4 things. The first one is time average wall shear stress, which demonstrates the average shear magnitude over a cardiac cycle. Oscillatory shear index demonstrates the directional oscillation of each of those shear stresses, and it's a unitless number from 0 to 0.5. And relative residence time, what it does is that it quantifies how often do low and oscillatory shear stress spend time around the wall. And that especially has been implicated in aneurysmal degeneration. And finally, we looked at true and false lumen pressure differential, calculated as pressure in the false lumen minus pressure in the true lumen, normalized to the true lumen. But to make a model, we need a gold standard. We need to know what we're comparing against. And this is where we were very fortunate. Through REB, we were able to obtain consent, and we evaluated arterial pressures from a 55-year-old gentleman with a remote history of an uncomplicated acute type B aortic dissection. We measured the inlet at the level of the ascending aorta, and then we measured the true lumen and false lumen at the level of zone 5 of the aorta, just proximal to the celiac axis takeoff. And that formed our pressure-informed model. We can't get any more ground truth than that because that is coming straight from the patient itself. Spoiler, we've already made the model, and I can't unfortunately show how we made that model, but I can describe the certain changes that we made on the model. In terms of the pressure model, the inlet and outlet are pressure. There are no changes to the geometry. We then made our model that is scalable to patients, and we're calling it the combined WK model, or combined Windcastle model. What that does is that for the inlet, it can take any parabolic velocity profile. All it needs is for you to scale the cardiac output to the patients, and you can do that through an echocardiogram. The outlet is a modified Windcastle, and what does that mean? Well, we can represent distal resistance of blood flow as an electrical circuit, where pressure equals voltage, current equals blood flow, and resistance is resistance, and you complete Ohm's law that way. And when we do that, there is one geometric change that we have to do. We have to combine the distal lumen because we don't know the fractional flow in the true lumen or the false lumen. So Windcastle with our modification can only work if we combine it. And combining it is only one of the geometric changes that we've made. There are others that hopefully one day I can share. And when we want to look at pressure differentials, we want to look at pressure at 3 different time points. We want to look at peak systole, mid-systolic deceleration, and diastole. And we want to look at these 6 planes over here, where you can see plane 1 is actually the intimal tear. You can't see a separation between the true lumen and the false lumen over there. Planes 2, 3, 5, and 6 have separation of true lumen and false lumen, and plane 4 is a large fenestration. So over here we have 3 graphs at systole, mid-diastolic deceleration in the middle, and diastole on the right. This represents true and false lumen pressure differential. Blue is our pressure reference model, and orange is our combined Windcastle modified model. And what we can see here is that especially in mid-systolic deceleration and diastole, we have very good agreement with absolute median differentials of less than 1%. It's at systole, especially in the last plane, where we do see some differences, but even then, the absolute median differences at each of those planes is less than 3% between our model and our pressure reference. Well, what about the planes where there's just a connection and you can't separate true and false lumen? Here we can do the median Pascal pressure at each of those slices, and again, blue is pressure informed, orange is combined Windcastle, and we have good agreement this time in systole, diastole, but it's really mid-systolic deceleration where we see a 15% differential in the median average pressures in plane 1 and plane 4. What about the hemodynamic metrics? Well, when we look at hemodynamic metrics, it's not important that each of these values align 1-to-1, but that the pattern and the ratio is existent. So what are some things we can look at here? The first thing is the intimal tear, and we can see a sudden spike in time average wall shear stress at the level of the intimal tear. And we can see that in our model as well, and it's replicating exactly that. The other thing we can see are different areas along the true or false lumen that do have high time average wall shear stress, and we find that our model replicates that as well. Now what we wanted to look at is what's the ratio of the true lumen to false lumen of those parameters. And what we see is while there is a relative change of 20% between our models, the ratio is 0.78 versus 0.94. And so it keeps the ratio below 1, which is what we wanted to see between the pressure and our combined models, so that it is in fact, in agreement with our model. We also did this for OSI and RRT, and we found the same pattern, where there is a median absolute difference, but the ratios still hold. And if the false lumen OSI is higher in our pressure model, it'll remain high in our combined model. But that wasn't enough for us because we wanted to stress this further. So with our cardiac surgery colleagues, we were fortunate enough to find a patient with a history of a repaired type A aortic dissection with the residual dissection now remaining in the descending thoracic aorta. So in a way, it is behaving as a type B dissection. But one thing that's interesting in this patient is that they have a stent-induced new entry tear labeled there. That means the frozen elephant trunk that was placed in the descending thoracic aorta has protruded its way into the false lumen and is now perfusing it. As it goes for complex anatomy, I think this is as complex as it can get, with also debranching, with only one branch supplying the head and neck vessels, as you can see at the top. And again, we see very good agreement between our model and pressure reference model. The only difference, again, that we see here is in plane 4 of the systolic, where it goes from a differential of 2% to 0%. But even then, the median absolute differential is 1.65%. We found the same results when we looked at hemodynamic metrics, including TWSS, shown here, along with OSI and RRT. So overall, these results show us that CFD simulations are highly sensitive to how inputs, outlets, and geometry are defined. However, our combined Windcastle approach appears to preserve important lumen-specific pressure and wall metric patterns, particularly outside the peak systole and communicating planes. And therefore, we do think that it defends to use this model as a scalable framework for future CT-based cohort studies. There are limitations to the study. The first one is, in fact, that we did use a rigid model, and we are now testing fluid structure interaction with it. And we've only tested it to baseline or to pressure models. We still need to test it to 4D MRI, which is actually a higher order of value because it not only gives you the value of the velocity, it also gives you spatial representation through a vector. And that would be one of our next steps before we can apply this model to patients that became aneurysmal and those that didn't, and try to find if we can predict which patients are high risk for aneurysmal degeneration. I'd like to acknowledge and thank my supervisors, Professor Saman, Drs. Lindsay and Dr. Crawford for vascular surgery, and of course funding, and very grateful for that from CIHR, including Dr. James and Mary Rutka Scholarship. Thank you.
Great work, Dr. Mahmoud. I'd like to invite Dr. Sogoli Khuzai to come ask a few questions, please.
Hi, great presentation. Thank you very much. I have 2 questions about your future, actually the direction of your work. You already mentioned about your limitation. I have a question. How close do you think you are in using this approach in real-time clinical consultant to patients? And how do you see that your framework can integrate with MRI that you're usually using for other aspects of that?
Yeah, great questions. Every day I feel like I'm getting behind, and every day it's feeling like it's getting far where I can actually use this model, scale it, bring it about, put some IP towards it. But the reality is that when it comes to FSI that we mentioned, when you're looking at wall-based parameters that are predictive of aneurysmal degeneration, there's many studies in abdominal aortic aneurysms that yes, FSI is more precise in terms of the values that you would get for those hemodynamics, but when you're evaluating those values versus the resource that it goes to compute that, a rigid model currently takes anywhere from 105 to 130 hours of just running the simulation. That's without pre-analysis and post-analysis. FSIs can take anywhere from a week to a month for a single patient. And if the results demonstrate that they're not that sensitive to predict hemodynamic or to predict aneurysmal degeneration, I think it's still fair for my PhD to do a case and to show that. But I don't think I would be using FSI to scale that cohort study because it would be very time intensive in that way. Where do I see this going? I do think that we're in an area that hasn't been researched upon yet. because the sections, in true honesty, are very difficult to run on CFD simulations. We are the first ones to have a model that demonstrates anything close or resembles to a ground truth. And I think from there, we'll continue to verify through 4D MRIs to do the vectors part, or for the velocity, and then do our own institutional patient outcomes, see what the results are that we're getting, and then move forward from there. I do hope I can use this in patients real time. That is my goal, to see a patient in the emerge and know, are you high risk or not? Can we bring you back in a subacute phase when you're out of the clear and give you that T-bar? And I'm hopeful that through these steps, I'll get there.
Great. Can I ask you a question, Dr. Mahmood? So, I mean, this is phenomenal work. Do you think, I mean, you obviously developed this in type B aortic dissections, but can the exact same procedure be done for vascular degeneration in general in other areas of the body? Just understanding the kind of limitations of getting a model and the gold standard inputs, but could this same approach be applied to other areas of the body, you think?
Absolutely. And a lot of the lessons that I've learned have been from engineers that have developed it in AAAs. A lot of them are in Calgary, including Professor DiMartino. But when we have the model, that's just hemodynamics. So if we're thinking AAA, for example, AAA needs another layer. That layer is interluminal thrombus, because the thrombus impacts the pressure now of how much does the wall take and how much does it not take. And so you can use it for a ground truth, but you still need to build up those layers. So even in this type B dissection, one of the things we are working towards is how do we represent thrombus in the false lumen? Because there is a question of, is a thrombus protective or is it not? And that needs to be a layer. If you think about a 3D mesh, you need a layer within the 3D mesh that has a squishy thrombus that can actually mimic what's going on in there. But yes, it can be used anywhere else.
Great, congratulations, well done. Next, we have Dr. Adri Conker joining us. He's a third-year urology resident, and he's going to be speaking to us about redefining urinary tract infection risks for children with primary obstructive megaureter.
Perfect. Perfect. Well, good afternoon, everyone. My name's Audrey, one of the urology residents here, and thank you so much for the chance to present today. We've been working on this topic of hydronephrosis and megaureter for the last few years now, and I'm really happy to share the results with you today. So hydronephrosis, otherwise known as swelling of the kidney, is quite a common finding, especially in small children. It happens in about 1 in 20 kids, and for a pediatric urologist, it triggers a very specific workup. We're trying to find out if there's a blockage somewhere along the urinary tract, in the proximal ureter, distal ureter, in the bladder, or the lower tract. The reason we do this is because these kids are especially at risk for things like urine infection, kidney problems, and can often need surgery. A subset of these patients will also have hydroureter, and that's dilation of the ureter itself, and these can be classified as those with megaureter. Now, when it comes to managing these kids, a lot of the evidence early on, 20, 30 years ago, would suggest that these patients should be on antibiotics from day 1 of life until a certain year of age. Or if there's obstruction, treat it early and take this patient to surgery. But we learned over the last 20 years that this likely led to some overtreatment, and the guidelines are a lot more selective in how we manage these patients. So for example, when it comes to infection risk, the Canadian guidelines suggest that antibiotics prophylaxis is warranted if they're female or uncircumcised, if they have really bad hydronephrosis, or if they have significant hydroureter. Unfortunately, that recommendation is based on very low quality evidence. When it comes to dealing with the obstruction and going to surgery, the British guidelines say that watching these patients conservatively is okay, but doesn't really help us prognosticate when is it not. It also comments on how surgery can be challenging, especially in small children. And this brings me to the research questions I want to talk about today. So first, we know risk stratification for UTIs is quite poor in the moment. Can we do better than that? 2, we know that a lot of these patients will get better without surgery. Can we help predict that? And lastly, we know that surgery can be quite challenging, especially in small children. Are there ways to improve that? To answer any of these questions, we need to first create a hydronephrosis repository. And we've been doing this at SickKids, looking at our referrals for patients with hydronephrosis less than 2 years of age and excluding other anomalies such as reflux or lower tract obstruction. We looked at a set of common predictors that would be widely accessible: age, sex, and then first ultrasound features. From that, we got measures like APD, which is how dilated the renal pelvis is, a measure for hydronephrosis, SFU grade, which is another score for hydronephrosis, and then ureter dilation, which is how wide the ureter is in millimeters. From this, we can predict outcomes such as infection, resolution, as well as surgery. When we first look at infection, we included a cohort of around 800 children, of which 15% of them had clinically significant hydroureter, more than 7 millimeters, based on the guideline cutoffs. We followed them for about 2.5 years, and within this whole group, 4% of patients developed a urine infection. Now, if you look at just the patients who had significant hydroureter, more than 7 millimeters, this group had an infection rate of 13% over follow-up, compared to 2% in those without significant hydroureter. This group also had more significant hydronephrosis and more likely to be on antibiotics. Now, if we break this into the categories of hydroureter, we see that patients with more dilation, more than 10 millimeters that you can see in the green, were at increased risk of an infection over follow-up compared to those who are at 7 to 10 or 0 to 6 millimeters. And we can pull out the hazard ratios from this, and it shows that if you have increased ureter dilation, you're at an increased risk of infection over follow-up. But as I mentioned, there's more than just one measure that determines a patient's risk of infection, and we checked for this using a multivariable Cox regression, including those predictors I mentioned earlier on. And what it shows is that if you're a male who's uncircumcised, or if you're a female, you're at an increased risk of infection. That's pretty widely accepted. This study was the first to show that hydroureter, for every millimeter of dilation, you're at an increased risk of infection, which is clinically important. But what was surprising to us was that hydronephrosis severity by either SFU or APD was not significantly associated with the risk of infection. And this is different from what the guidelines suggest. This corresponds to the majority of patients who just have hydronephrosis, where we would give them antibiotics if it's severe enough. But our study suggests that this group of patients might not really be at risk for infection. And this finding is guideline changing and will likely alter the upcoming Canadian guidelines on this topic. This study is the largest comparative analysis to date looking at hydroureter, and double in size compared to any contemporary study on this topic, showing that hydroureter is a risk factor, whereas hydronephrosis might not be. It takes our current guidelines and it would help modify it to better risk stratify patients for who deserves antibiotic prophylaxis and who would benefit from it. Of course, although the study is large, it comes with some limitations. It's a retrospective single-center experience. We had to adjust for antibiotic prophylaxis within that, and there were some clinical practice changes. But despite that, this study will be published in the upcoming month's issue of the Journal of Urology, which is one of our very important journals, that suggests that for a patient who has hydroureter, they're at increased risk for infection. But if it's just isolated hydronephrosis, it might not be the case. Next, I want to spend some time to talk about the risk of obstruction. We know that a lot of these patients with megaureter will resolve with expectant management. We looked at the patients in our repository who had just hydroureter, and we again looked at those predictors such as age, sex, and the first ultrasound. We defined resolution as improvement in hydronephrosis or hydroureter over consecutive clinic visits, so quite a pragmatic definition. We followed these patients for about 2.5 years within this cohort, and within that time, 56% of them met criteria for resolution. Now, when we look at these ultrasound features that we would like to use as prognosticators, we see that increased APD, or more dilated pelvis, or a higher SFU score, worse hydronephrosis, was associated with a longer time to resolution compared to patients who had lower values. When it comes to ureter dilation or ureter tortuosity, same idea. The more severe the ultrasound findings are, the less likely you are to have spontaneous resolution of megaureter. And although this intuitively makes sense, this was one of the first studies to show this quantitatively. Now, when we think about these 4 ultrasound metrics, which are available to us at that first clinic visit with the patient and the family, it can help us prognosticate what we should be offering for this patient. If for a patient who has 2 or more of these ultrasound findings, they're at increased risk for non-resolution and might warrant heightened follow-up and even consideration of early surgery. We compared this kind of prognostic model against the others in the field, and it performed with a superior AUC comparatively and to help us prognosticate. But again, clinic's busy, looking at 4 predictors can be challenging. Just using APD, which is easily accessible on any pediatric ultrasound for these children, was good enough in helping us prognosticate these patients. And an APD above 15 millimeters was associated with non-resolution in this group. But again, to make the study stronger, it'd be nicer to have longer follow-up and external validation of these results. This study, though, demonstrated that APD itself could be an important risk factor, prognostic factor for looking at these patients in the long run. For the last part, I'd like to spend a second to talk about surgery. Now, in an ideal world, these kids, 1 in 5 of them will require surgery because they keep getting infections or they're having kidney damage. You have this blockage in the distal ureter. You would take it out and perform a proper reimplant. However, this can be quite challenging, especially in a small child, where the dilated ureter can be almost the same size as the bladder. But you still need to do surgery. So an option is to perform a temporary cutaneous stoma, but this commits that child to a later definitive surgery when the child's older and you do a proper reimplant. Another option that we do at sick kids is called a refluxing ureterovesicostomy. Here, we leave the distal blocked ureter alone, and we make a cut on the side of the distal ureter and the side of the bladder and create what's called an internal diversion. You bypass the obstruction, but arguably might be committing this patient to reflux in the long run. And we wanted to see if this was truly, what would happen to these patients as we follow them. We had 47 children who underwent a ureterovesicostomy with about 4 years of follow-up. We see that when we look at their metrics for hydronephrosis or hydroureter, over time it does improve, so the surgery is treating the obstruction. Importantly, when we look at their complication rates, it's low. 15% of patients had minor 30-day complications. Importantly, 70% of children did not have any infections, which we'd be worried about in patients who have reflux over follow-up. And 85% of children did not require a second surgery after, whereas in megaureter. So again, this offers an alternative way to perform surgery for these patients who need it that might be more technically feasible and might not commit patients to a second later surgery. And that was again published in the Journal of Urology in 2024. So in conclusion, thank you for going on the whirlwind of megaureter care with me today, but I hope I've shown you how at Sick Kids we're trying to improve the management for these patients by looking at different kinds of risk stratification and tools. So thank you so much for your time, and thanks to Armando, my mentor.
Congratulations. Wonderful body of work. I'd like to invite Dr. Randall Mata to give a few questions, please.
Hi, Adri. Congratulations. This is really excellent work. I'd like to commend you because you're not an SSTP resident and you've pulled off such an impressive body of work. So I think that deserves a special recognition. But my questions for you. So just with respect to the surgical approach that you talked about in your third point there. Yeah. You talked about basically taking a patient with a megaureter and turning their obstructed system into a refluxing system. So you've kind of exchanged one problem for another. As some people might know, reflux in pediatric urology, vesicoureteral reflux is something that is treated with antibiotic prophylaxis and surgical treatment. So why not proceed with a surgery that could fix both reflux and the obstruction at once and sort of eliminate the problem entirely?
Yeah, it's a really good question. Thanks for your kind words, Dr. Mata. Initially when I heard how we from the person who developed the surgery in 2005, how what happened, it was for a patient who was quite sick in the operating room and he just needed a bailout to try to get this patient through this megaureter. And it wasn't meant to be a definitive end-stage procedure. It was supposed to be internal diversion, go back later to do a formal reconstruction. And that's exactly the worry, right? That if you have reflux, you're going to predispose these children to an infection and other problems in the long run. But that's why it's surprising to us that in this follow-up, only 30% of children over 4 years of follow-up developed any urine infections at all. That yes, they have reflux, it's asymptomatic though, and it might not require that later surgery. So, it's genuinely a worry that we had, but the data supports that it's okay to watch these kids with asymptomatic reflux in this case.
Yeah, I think it would be worthwhile in the future to really explore why that type of reflux is different than patients born with reflux.
Yeah, for sure.
The next question I had was related to your first question and your first study that you discussed. It seems that the urology guidelines in pediatric urology with respect to antibiotic prophylaxis are really lacking in terms of the evidence that supports them. It's based on a lot of small studies and expert opinion.
Yeah. Yeah.
They are nonetheless retrospective studies just like yours.
Correct.
So why is your study better than what's previously informed the guidelines, like other than the things you mentioned in your presentation?
Yeah, that's a really, really good question. Our study is large, and that's the one benefit of it, but it comes from a very large cohort of patients from a wide catchment that we really, one of the few places in the world that has a sick kids because of how large the geographic area is and how many patients we see with this. So, you know, the largest other study within this group was from a multi-center registry from the Society of Fetal Urology with multiple centers, but the accrual within that was about 250 patients over the same time length. So it's very difficult to do these studies. And within pediatric urology, you know, it's a field where we have a lot of diseases that don't come up like how often you see hypertension in an adult. You're working with kind of data that cannot achieve that same quality or level of evidence, and you have to make decisions within that. So, you know, yes, it's a retrospective single center study, but to date, it's the best one in helping us inform the guidelines for it. So it's kind of within the context of the field.
Do you think a level 1 type of study would be feasible here, and what would be needed?
Yeah, I wish, I hope so. One of the best way to study this would be a randomized trial where we take patients with hydroureter and randomized to antibiotics or not. And this study kind of, I think, gives us the clinical equipoise to do that in the future. But that ideally, yes.
Great, thank you.
Congratulations, well done. Okay, and our next speaker is Dr. Stephanie Jiang. She's a general surgery resident and working with Dr. Caroline Moulton. Her title of her talk is very intriguing: Sunset or Sunrise, Identity, Motives, and Meaning Making in Retiring Surgeons. Welcome, Dr. Jiang.
Thank you. So I'm Stephanie, I'm in general surgery, and today I'll be discussing our project, Sunset or Sunrise, Identity, Motives, and Meaning Making in Retiring Surgeons. So this project is funded by the Royal College's MERG, and there are no conflicts of interest. So I'll begin with this question: who are we at the end of our careers? For many of us, our job is a huge part of our life. For some of us, it may even be who we are. So what does retirement do to your sense of self? And what does it do to a group of people created in a culture as strong as surgery? The surgical identity is often presented as homogeneous and pervasive, built on mastery, endurance, and control. It is a culture that rewards strength and self-reliance, upholding the belief that surgeons can manage anything, even profound change, alone. However, behind this myth of infallibility are real people who, at the end of their careers, are struggling to manage the complex psychological, social, and cultural transformation of their long-held surgical identity. By examining how the surgeon's identity interacts with surgical culture during aging and retirement, we can not only sustain good medicine, but uphold the humanity of those who practice it. Our qualitative study used constructive with grounded theory guided by identity process theory. We conducted semi-structured interviews with surgeons at U of T who were nearing or in retirement. So I know we're not psychiatrists, but here is a very quick psych lecture. Identity process theory helps explain how people respond when a central identity is threatened. In that situation, they may either assimilate, so hold on to the old self, or accommodate, reshape their identity to fit a new reality. Identity is also shaped by motives like continuity, self-worth, belonging, and meaning. The more one identity fulfills its needs, the more central it becomes. So this gives us a very good framework for understanding why some surgeons are able to adapt and while others may struggle to move on. So in total, we interviewed 17 surgeons, 7 of which who were female. Specialties varied and are listed here. 8 were retired, with an average of 3.6 years into retirement. One of our main findings was that the surgical identity was a central component, if not the central identity, of an individual's identity structure. And this was due to its significant contributions to feelings of continuity, distinctiveness, self-efficacy, self-esteem, belonging, and meaning. It is a bit strange to go from being somebody that got sent the tough cases and was teaching fellows from around the world to doing the scopes that anybody else can do. So this is a clear example of distinctiveness, being unique from other careers and people. I was proud to call myself a surgeon. I was proud to have trained at U of T and establish the professional connections that I had with the university and the various residents and fellows I worked with over the years. And this is a clear example of self-efficacy and confidence in one's own ability and control over one's life. You do things during your day in the operating room that nobody outside that area understands or has a vision of or even knows the feeling of. That's what I miss. I miss the people. And this is an example of belonging in an irreplaceable group. And lastly, is being a surgeon something I would want help giving up? Or am I happy with the fact that this is who I am? I mean, again, I don't flaunt it. I don't advertise it. But in my heart, I feel I made a difference on this planet in a couple of ways. And this is a very good example of meaning and life purpose that surgery brings. Retirement became a new reality that challenged the surgical identity and brought with it an emotionally complex terrain with feelings from relief to fear and bittersweetness to joy. Despite working in a culture that promotes stoicism, the experiences of our participants remind us that distancing yourself from emotion does not prevent you from feeling them. Retirement was like a melancholic moment when you realize that you're passing through a threshold and there's no turning back. Participants grappled with self-perceptions, colleague attitudes, and institutional culture. A host of push and pull factors, including burnout, health concerns, and financial considerations, were added to this landscape of this transition. And with that in mind, our study created this conceptual framework that positions the surgeon's retirement experience along a sunset to sunrise spectrum. Sunset retirements were dominated by identity assimilation, so minimal to no identity change, with very little identity accommodation. The surgical identity was perceived as the primary or sole source of satisfaction of identity motives. I just hate to give it up. I just hate to cut the strings completely. I don't know. There definitely is a lack of meaning in retirement, for sure, and I'm searching for something that has more meaning for me personally. Retirement limited access to the clinical practice of surgery, the surgical community, and adjacent responsibilities, thereby restricting the enactment of the surgical identity. This led to diminished sense of continuity, distinctiveness, belonging, and meaning. Surgeons in this group often struggle to let go of their surgical identity and in turn face great difficulty in building new ones. I'm gonna go crazy. I'm gonna be bored to death. You spend so much time doing surgery, it defines you as a person. You spend so much effort and energy into it, it's hard to switch gears, especially when it gives you a reason to get up in the morning and you feel good about what you do. You feel proud of your work, and then all of a sudden, that's gone. Sunrise retirements, on the other hand, were characterized by identity accommodation, so the changing or embracing of new identities, alongside selective identity assimilation. The surgical identity could remain central, and in some cases, it was shed completely, but it was not the only source of self-esteem, meaning, or belonging. I tried very hard to build surgery around my life as opposed to building my life around surgery. I've always known that surgery was just a means to an end. I always knew I was a great person before medicine. I could be a great person after. Individuals with sunrise retirements actively search for or embrace new identities, such as being grandparents, authors, sailors, or bird watchers. These roles were not considered less meaningful or substantial than the surgical identity, but it's equal. After decades of sacrifice to the career, Sunrise participants realized that there was a whole world outside of surgery that they could explore. So I find that this part of my life has been a sunrise since retirement. I always had lots of ideas. My mind was never idle, but I wasn't able to act on them because my job was all-consuming. But I'm worried about my other identity just as much. You know, what about the other me that I haven't really gotten to know so much? Retirement is much more than the end of a career. It is a complex, dynamic, multidimensional transformation of identity and self. This process is shaped by the centrality of the surgical identity and its fulfillment of identity motives. When these motives are satisfied by surgery alone, retirement threatened the self and resulted in a sunset, marked by fear and loss. When motives are satisfied across various roles, individuals would experience a sunrise, the beginning after the end, a period of renewal and possibility. These findings further highlight a major gap in surgical education and professional development. We invest so much for people to enter the career, but we almost invest nothing in helping them exit it. However, this does give us a very good opportunity to turn this threshold into a space of transformation rather than decline. So what can we do? At the individual level, we must explicitly name and normalize the process of identity transformation. Structured exercises include identity mapping, guided reflection, and facilitated discussion, and this may all help guide participants towards parallel identities. Early planning for retirement, including taking a sabbatical or pursuit of an encore career, so those are careers that are unrelated to the previous job, or an echo career, careers that are related to the previous job, all of this may be beneficial for this transition period. At the collegial level, we must reduce isolation and learn to honor our relationships. Peer-based story circles and passing the baton workshops could create space for mentorship, legacy, collective meaning-making, and continued belonging. And at the institutional level, we may move from silence to scaffolding with practical interventions that may include a designated retirement liaison and navigator, structured farewell rituals, retirement checklists, such as how to close a clinic or what to do with patient files. And all of these measures acknowledge that retirement is not solely an individual responsibility, but an institutional transition. And lastly, at the transcendent level, forums that address spirituality, philosophy, gratitude, and meaning and action may help surgeons articulate their purpose. Encouraging concrete meaning projects, teaching, writing, art, or mentorship may further help distribute identity motives across differing roles. And perhaps most importantly, it is this reminder throughout your training and your career, your emotional and spiritual health is not separate to surgical excellence, but rather they are fundamental to it. And I'll end this presentation with a quote from Carl Jung: "The afternoon of life is just as full of meaning as the morning, only its meaning and purpose are different." This study and its implications span beyond solely surgeons. The exploration of the psyche of retirement has been a long-standing field of fascination, and Carl Jung reminds us that during this time, we may finally have the chance to be oriented inwards and ask ourselves the question of what truly brings us meaning. I would really like to also thank our participants for sharing their stories. It was an honor to hear them. And these are some groups that are available at U of T for anyone who is interested in helping their retirement transition. Thank you very much.
Congratulations, Dr. Jang. I'd like to invite Dr. Paul Walker for some questions, please.
Thank you very much, Stephanie. I found that paper particularly stimulating and addresses a very important issue. Under the leadership of our current chairman, Dr. Carol Swallow, there's been much greater focus on the challenges of being an academic surgeon. Strategies for still contributing without some of the negative forces have helped develop pathways for more balanced life and perhaps more personal development. However, this paper describes the challenges of not being an academic surgeon. And it addresses, to me, the colliding agendas of stopping performing surgery, leaving the hospital, along with the aging of body and mind, and loss of income. Pre-planning for aging issues has been stressed broadly and has shown results. Pre-planning financial issues is imperative. After living on a high cash flow for so many years, living on net worth, that's your assets minus your liabilities, could be a shock if you aren't prepared for it and it's managed. This paper focuses particularly on the aspect of loss of personal identity on retiring and the potential mechanisms to deal with it. It includes the discussion of the difference between the response of assimilation or association, which is what resonated with me, and their potential for more positive retirement. So I have a couple of questions. Now, your second last slide actually wasn't in the paper, and so that's a lot of my second question. But the first question was, you had 17 responses, 7 were women and 10 were men. That's not the distribution of gender within a department of surgery. So I'm just wondering if, first of all, why? Why did you have 10 and 7? And secondly, was there a difference? Was there a difference between men and women? I know both samples are relatively small. But if you go back, if you don't mind, go back to your second slide, because that's really my question. Not that slide, that one. So the question is, what are the potential mitigating factors prior to retirement to help guide surgeons through the initial phase, perhaps leading to more association than assimilation? So my question is, from my reading of what you've done, assimilation is not as positive as association. And number one, is that true or not true? And secondly, if it is, assimilation seems a lot easier, and it allows people to keep coming back to the hospital or keep doing something, as opposed to recognizing, admitting, and understanding the changes. So it seems to me that association is a much more powerful sunrise. So could you answer those two questions? To be specific, how do you get more people, how do you train more people to associate, not assimilate, when they retire? Thank you.
Thank you. So I guess I'll start with that part about helping people to learn how to proceed with identity accommodation over assimilation. I think that really starts with the self as well as the culture. At the level of the self, we need to be able to develop an awareness of our identity and an awareness of your own emotions and how you are living your life day to day. I know there's a lot of research and literature looking at mindfulness, but it is a very important aspect of knowing you're not continuously on autopilot and being able to sit down at the end of the day or week or any moment and actually be able to understand who you are and where you may be at. But this really interacts with the culture of surgery, and that's really where we have to work towards building one that allows that vulnerability and builds that emotional depth as strength rather than something that you should be pushing away. And this is like a cycle, and will be a positive feedback cycle where if the culture allows for that expression and you're able to have discussion with colleagues, you're not feeling completely alone in the experience, and that you are given opportunities to learn to be someone else, or not someone else, but to build new roles and to be able to define yourself in new ways, then all of that will lead towards more identity accommodation. I hope that answers that question. If you could remind me of what the second question was. Yeah, so with qualitative studies, it may seem like it's not a very large sample at 17 people. However, this is where we reached theoretical saturation. It's just a concept of grounded constructivist theories. So this is where basically we had interviewed, we start with a couple of people first, and then based on that, we code the interviews, then we decide who we want to interview based on those codes in which direction. So that's sort of the constant and iterative approach. And then we will keep moving towards sort of the next question that may arise from the data that we've gathered. And we actually, after talking to the first couple subsets of participants, we realized that we were missing a female perspective. And so we sought out female surgeons that had retired. And you're correct, that's not the exact makeup of our surgical departments. However, we thought it was important to be able to see both sides of the perspective, especially since there are different roles and we're brought up in different ways, depending on gender as well. But yeah, thank you.
What was the difference?
Oh, sorry. So
that was my question, Carol, but thanks.
Yes. So, we would hope to interview more to have a more robust difference, but the female participants were a bit better at identity accommodation, so able to build the social lives as well, to find communities a bit easier, and appear to be a bit more flexible. However, we would want to interview more surgeons and to have that as a focus of the study before we would make any big claims about it. Yeah.
So thanks. I think that was a very interesting final selection for the program. And I want to congratulate you and Carol Ann for really having a provocative topic, because in many ways it's often been another elephant in the room. There's many elephants in surgery. I was just in France, and I was able to do a final clinic with Professor Sylvie Bonvelot, who is an innovative surgeon in retroperitoneal sarcoma surgery. And sadly for her, she's 67 years old, and in France it's a hard stop. You're out. Like, it's done. So I really think there's so much more to do. And I really hope we continue this dialogue, because succession planning, what we've done in our research institute locally at LTRI is we actually now have a Professor Emeritus Lounge that allows this opportunity to drop in and stay connected and provide ongoing feedback. So I think there is so many ways, there's so many lessons that people can share. And age, as we know, is a little bit more transient than the French have defined. So congratulations on your work.
Thank you so much. Thank you.
One more question? Can I do one more question? Sorry.
Yes.
Thanks so much. In Death of a Salesman, there's a line that goes, attention must be paid. And it's the line that makes most older men in the audience weep, because it's a loss, it's a recognition that, you know, Willie Loman was a person and he had worth. And so this is very, very salient and emotional for a lot of people at the end of their careers. I'm just wondering, as an educator, is there anything we can learn from the ramp up to becoming a surgeon, where you're forming the identity, that we can learn to apply to the ramp down? Mm-hmm. So have you thought about that, like how identity gets formed, and thinking about that as a way of kind of unwinding one's, not so much identity, but maybe putting you back into a safe space?
That's actually a very interesting point to bring up. I think that Keegan's model would actually be very useful in this deconstruction of the identity, especially as you're seeing the social components, you know, moving from the extrinsic reward to intrinsic reward. So I think that we could actually really look at Keegan's model, especially that final stage of developing that meaning that's outside of the culture or workspace you may be in. And yeah, that would be a very interesting direction for the study to go in, actually. Thank you so much.
Yeah, that certainly was an interesting a talk to end, but it's really been a remarkable a day, and you know, wow, it's been really cool. So a big thanks to Professor Ram Nataraja, amazing lecture, and it's much more than a lecture that you gave, because it was really a stimulus for us to put this symposium together, and this has also been a stimulus for us to consider how to, you know, bring what I think is really a lot of fantastic work in, you know, these areas of robotics and simulation together. And we were mentioning, you know, potential opportunities for collaboration between Toronto and Melbourne, which I think would be amazing. So many thanks to you. A big thanks to all of the trainees who gave amazing oral presentations, and the e-posters were fantastic as well. And a big thanks to all of their supervisors and the teams, because, you know, obviously this is a really big a team effort. I acknowledged you know, the many people that contributed today. I want to in particular thank the various e-poster judges who are upstairs, and I was kind of wandering around among the sessions, and were really vibrant discussions. We're very, very appreciative of that, very appreciative of all of the judges, the discussants, the moderators today, and a big thanks to our research committee, and a big thanks to our administrative staff, in a particular a shout out to Renata Musa, who is now working very hard tallying up the scores and so on. So she's done an amazing job. So on that note, I'm going to close out our 52nd Gallie Day. Wow, that's pretty amazing. And I will hand things over to our chair, Professor Swallow, for final comments.
So thank you, Michael, and thank you, Michael. We also have to acknowledge how much work Michael, as the Vice Chair of Research, puts into this day, and it is just a phenomenal unifying moment for our department. I also want to thank all of you who are here. Just by being part of the day, you tacitly participate, even if you didn't get up and say something. And I really value that presence and participation. So thank you for being here. Yes, there are a few people I'm going to point at for being here. And remember, tonight, there's only one place to be in the city of Toronto. 7 p.m., Shangri-La, cocktails begin. 8 p.m. dinner, all the amazing glamorous awards are going to be presented. You want to be there. So we will see you. Thank you for being part of the day. Thanks, Michael.